You're now listening to MedEd Talks Rheumatology, a Vindico Medical Education production. To view CE information and claim credit, log into mededtalks.com and search Lupus Nephritis, Advancing Equity in Care and Research, or click the link in the notes section of this podcast. Now, here's your host, Dr. Sam Lim.
Hello, and welcome to Lupus Nephritis, Advancing Equity in Care and Research. This continuing education activity is provided by Vindico Medical Education and is supported by an educational grant from Genentech, a member of the Roche Group. I'm your activity chair, Dr. Sam Lim, professor of medicine and epidemiology and associate director in the Division of Rheumatology at Emory University, as well as chief of rheumatology for the Grady Health System in Atlanta. In this 3-episode podcast series, we'll be discussing health disparities in lupus nephritis, the critical importance of diversity in clinical research, and strategies to enhance equity in care for all patients with lupus. I'm joined by my colleague, Dr. Ashira Blazer, assistant professor in the Division of Rheumatology and co-director of the Lupus Center at the University of Maryland School of Medicine in Baltimore. Welcome, Ashira.
Hi, thank you so much for having me.
Great to have you. In this episode, we'll be discussing disparities in lupus nephritis and access to care. So let's just dive right into it. We often see the statistics on disparities, but they can feel abstract. Help us understand what those numbers can mean for the day-to-day lives of people with lupus nephritis.
Yeah, I think that's so important because, there's one thing to see numbers and another thing to see patients. And I think one thing about lupus nephritis is once it happens, you're at continuous risk of having another flare. So that means that patients have to have continuous access to high quality healthcare and medications indefinitely. And so that may mean a patient who ends up with disability because of their lupus loses access to their medication and then develops a flare and ends up in end-stage kidney disease. That may mean a patient who can't afford medications is scrambling to figure out whether or not they should be taking a medicine or being able to pay rent, right? Many of our patients have to make these kinds of decisions.
That's a good way to frame it because we as clinicians, we think so much on disease activity and the outcomes related to that. And you make the case that it is directly related to disease activity in terms of the issues that affect disparities.
Absolutely. Yeah. I think when your basic needs are not met, often something like, should I be taking this medication every day, doesn't really register as something that's as important. And I think we really have to keep that in mind when we're taking care of these patients.
Good points. So for clinicians who may not see many lupus nephritis patients, what are some blind spots they may have when it comes to understanding disparities?
I hear all the time clinicians saying things like, oh, this patient is non-compliant, that patient is non-compliant. And they think of this as the patient made a personal decision not to follow my treatment plan. And that really is besides the point, right? So many of our patients have to have a good understanding of what it is they're supposed to do, and they have to have the self-efficacy to follow through. And so I like to think of it as treatment uptake, right? Especially when a person, over their lifespan may have a number of different challenges that affect them. And at a certain point, the lupus may not be at the forefront, right? Nobody has a kidney attack, right? So somebody feels fine. They don't understand that their kidneys are being affected by active lupus inflammation. And then all of the other things that happen in life become louder. And I think clinicians experience that in our own day-to-day lives, but we don't give our patients credit for also having those experiences.
Yeah, it's that disconnect between what's clinical, what's symptomatic, and what's also important to the patients in terms of their daily lives, putting food on their table, a roof over the head versus trying to address this proteinuria that we keep talking about. That's really the heart of the matter that you bring up. And, I think about also another blind spot, if you will, like, visually losing sight of someone is that I think all of us have a sample bias in terms of
the impact of these disparities, especially for rheumatologists, when some of these patients go into kidney failure, they sort of get lost in the world of dialysis, and they may not come back to us as much. So we don't get a sense of the ultimate impact sometimes. And even for someone that thinks about it and studies it, it just doesn't come across to us day to day, because most of our practice isn't people on dialysis. But that's such a huge impact that I think we lose.
For sure. Yeah. And just in general, how often our patients experience some kind of disability. I actually didn't understand that until I started talking to patients in community settings. And even things like, if you go on disability and then you get a job that doesn't cover all of your bills and certainly not your medications, now you lose your disability benefits. Or if you get married and that person that you marry has some sort of an income, but not enough to cover the expenses of your drug, now you're losing your ability to maintain your treatment plan, right? Those are reasons why we don't see our patients anymore, that we don't think about at all. And, I can't imagine saying, hey, I'm really in love with this person, but I can't marry him because then I can't get the medication that's going to keep me off dialysis. But those are the kinds of choices that our patients have to make in this society.
I've had to struggle with the word disability too, because, it speaks to empathy. Like, I remember a time, and still to this day, the word disability in the clinic setting kind of triggers me, like disability forms and stuff that really takes you away from what you think is more important. But actually, the whole concept of disability, as you point out, is so important and so relevant to the lives of our patients. Great points. How do you involve team members like APPs, medical assistants, or office staff in improving outcomes?
The first thing is engaging them. So we have such a disjointed healthcare system. It is so hard to even find who might be available to support our patients unless we have some sort of a medical home or some sort of intentionality in the way that we're building our clinical settings. So I think learning the landscape wherever I am and learning who might be available is the first step. And then the second step is just making contact and letting them know that what they're doing is important, and then gathering information for our patients so that it can be on hand whenever we need it. So a lot of that building bridges is what's important for engaging allied health professionals.
I know this is audio only, but for those of you who don't know me or haven't seen the video, I'm an Asian male. And, I practice in an environment where my patients are not Asian males. And so what I find so helpful is, whenever possible, hiring staff that's congruent to the sociodemographic of the patients whenever possible. And I'm telling you, over the years, I've learned so much from my staff because they've helped me understand what the patients are going through. Many patients will share with them things that they didn't feel comfortable sharing with me. And it's having also that culture within the office of this diverse staff to be able to share like that. I know we all focus on the business side of it, and appropriately so, and it's good to be efficient. But for those of you who haven't really thought about that aspect of the culture of your staff, whether they're congruent or not, to have open conversations as to what they're detecting from the patients along the lines of social determinants, that will really make everybody that much more engaging and effective. Let's switch over to talk about some of the newer things that are happening. We've seen some new therapies approved for lupus nephritis in the past few years, and there's going to be likely in the near future several more therapeutics. Do disparities in access extend to these newer treatments, and what can clinicians do about it?
Absolutely. And I think you're excited. I'm excited. I think this is the first time really ever that we have had so many therapeutics that might be effective for lupus, and that we have more that are on the horizon. And I think this is a moment sort of akin to the moment in HIV therapy where we got highly effective therapies for HIV, right? Triple therapy comes out, and there already were racial disparities before the highly effective therapy. But once the therapy came out, those disparities actually tripled. And what happened was the disparities existed because certain racial and ethnic groups lacked access to care before. But then now, when you have more of a bureaucracy, more of a cost associated with being able to have access to the most effective therapies, those patients fall even further behind. So I think we can take a lesson from that, because the medications that we are talking about on the horizon, or even the ones that just got approved, they are very expensive. They do require sometimes coming into an infusion center. They do require being able to maintain your insurance coverage and be able to take them long term. And patients who experience healthcare disparities have challenges with all of those things. So I think we have to think about, how do we improve access, just as much as we have to think about what medication might be effective for this patient.
That is a fascinating balance in terms of being hopeful, but also cautious. That exactly as you point out, I think it's being lost in some of our enthusiasm and discussion. The enthusiasm is well deserved, but there's caution there. And I also point to, currently with some of the new therapeutics that are there for lupus nephritis, it adds more complexity to the clinical visit. I don't know about you, but for me, the triple therapy that's in the new guidelines, if we talk about glucocorticoids and then mycophenolate, and then adding either belimumab or voclosporin, I have never been able to tackle all of those in a visit or two. It was hard enough for me to talk about the mycophenolate to begin with. And then this added biologic or small molecule, on top of everything else that they're dealing with the polypharmacy and getting access to these medications, it's really become a challenge.
It's a huge challenge. And even the pill burden, right? You go to a patient, you say, okay, you need to take your antimalarial 1 tab in the morning, 1 tab at night. You need to take your mycophenolate 3 tabs in the morning, 3 tabs at night. And then you need to take your calcineurin inhibitor 3 tabs in the morning, 3 tabs at night. And then you need to start taking the steroids, and you need to take 5 tabs for a week, and then 4 tabs for another week, and then 3 tabs for if somebody told me to do that, I would be like, I'll just see what happens. It's just not feasible. And so I think we really have to think about how a patient is able to accomplish this.
Yeah. And, there's the hope for cellular therapies in terms of minimal medications and durability of response, but we don't even know if people will accept that or, be represented enough in the clinical trials. And so there's a lot of questions amongst the hope. So let's keep that hope alive, but let's keep it balanced in terms of minimizing disparities. Let's move on. We often talk about disparities by race and socioeconomic status. Are there any unique gender-related issues in lupus nephritis that we should be aware of as clinicians?
Absolutely. So I think when you think about the stereotypical lupus patient, it tends to be a woman of color, right? And often men get overlooked, right? So lupus does happen in men, and it tends to be diagnosed later, and it tends to be severe in part because it is diagnosed later. And so I think we really have to have our eyes open for men with lupus and make sure they're getting screened and being screened for lupus nephritis.
Yeah, the men are so overlooked at times, and they're challenged with what a lot of people view as a woman's disease. And so I think that it's a very important group that we need to keep an eye on for sure. All right, let's wrap up. I want to ask you this final question. If you had just 30 seconds in the hallway with a busy nephrologist or rheumatologist, what's the one action you'd ask them to do differently tomorrow?
Take your patients off steroids. Stop overusing steroids, please, please. It is a harbinger of morbidity and mortality. It is the cause of many disparities. Can we minimize those steroids?
Do it appropriately. Don't do it too quickly, but definitely with the aim, get them up. I agree. So with that, I just want to say thank you, Dr. Blaser, for this excellent discussion. I always enjoy talking with you in any context. And thank you to our audience for listening. Please remember to take the post-test and evaluation to receive continuing education credit and to tune in for additional episodes in this series.
Thanks again for listening to MedEd Talks Rheumatology. CE credit can be claimed through mededtalks.com. For other episodes in this series, search for Lupus Nephritis, Advancing Equity in Care and Research.